And we'll record this session, and for anyone that's absent, give them the option of looking through the session. Hopefully that'll work out okay for them. Okay. Did everyone get a chance to vote? That could be where some people are. I think most of the polls close everywhere at 8 o'clock.
Yeah, we did. I did after work.
Good. Yeah, I had to run out and make sure because I'm like, oh no, I can't run out and vote after class. My goodness, that might cut it a little bit too tight for me anyway. And someone just chatted me. Jolene's going to try.
Lori, it's Theodora, by the way. Sorry to interrupt you.
Theodora. Okay, good. You got in all right.
Yeah, I was with Linda.
Okay, good. So you are here. Perfect.
Yes.
And Jolene is going to try a different computer. Cindy's here. Cindy O is actually Trent. So Trent is here. Perfect. So the only person we're missing is Megan. And Yolanda, who we already know is running a little bit behind. So that's all right. We'll start talking about crisis intervention and really just emphasize what you've already seen in the pre-work is that we want to make sure that everyone is in a safe environment. So it isn't just a safe environment for you as providers, but also for the client or patient, or whatever we call our the folks that we serve. And so, you know, there's a lot to be said for folks who are confident and also, you know, showing that stability in time of crisis. It doesn't always come natural, and sometimes, you know, folks feel a little bit nervous when things are going on that don't feel real safe. But usually a client doesn't know what's going on inside your head. And so, you know, just the ability to maintain that calm, cool, collected presentation can go a long way to helping them to feel safe in maybe their own shoes if they're not in a good place in the moment that, you know, we happen to be interacting with them. Any thoughts about your own agencies and safety and the environment and what they do to help you maintain that safety for yourself and your clients?
We had a training on de-escalation.
Oh, perfect.
Right, crisis de-escalation.
All right.
Calm a patient if he's going through a crisis so it doesn't escalate to.
Yeah, and so when you were looking at the pre-work and the kind of tips and pointers that were in the materials that you have, did it seem to be similar, or were there pointers that you all might learn in your own training that were different that you would want to add so some of your classmates could learn from you? There's other methods or ideas that you would want to share? It could be anyone. I'm sorry. Folks can chat things if you'd want to chat some ideas. If you have any that are in addition to the ones that are in the training, and if they're similar, you can just type similar or same, and just let us know that, you know, there's not an additional idea. All right, got nothing coming in right now, so I am going to table it for now and just kind of move on here. Encourage and promote courteous interactions. So embracing and valuing the diversity of clients. We are going to talk about culture and diversity next week. What does it look like when an agency is competent or not competent? Also, the bottom tier of the rung, when we're considering agencies that are competent or not, there is this idea of destructiveness, which, you know, that's when agencies aren't showing any competence at all around the importance of diversity and culture, and taking those things into account with our clients. So we'll get an opportunity to talk a lot more about that. But in terms of how that contributes to safe environments, how would you imagine that having a really culturally competent staff and agency, how does that promote safety? Just to kind of get your thoughts about that. This is going to be a long night. Oh, Quentin, good. Quentin. Thanks, Quentin. Quentin saved us all. He wrote, my agency had a really good de-escalation training upon hiring. Being in behavioral health, we also have a lot of opportunities for continued webinars and training. And as a BH professional, we're also given what I call screamer buttons. Yes, we have those on our keyboards where I work too. It's like a panic alarm, and you actually hit F9 and F11. All you have to do is put those two keys together, and it signals security that there's something going on in your area, and they come to your space. So yeah, screamer buttons, which are panic alarms. Most of the BH rooms in clinic have police connected panic buttons as well. So good to have. And it's also really good to know the policies of your agency, like who do we call if there's a problem, and that is going to contribute to your own confidence around your ability to respond to a crisis if it should occur. And then I'm not going to be leaguer, or if people really don't feel that they want to have a lot of conversation around how having a culturally competent staff contributes to safety. I will just say that it reduces the chance for misunderstandings. Now, misunderstandings are always going to happen, but they're not always necessary. There are times where it's just because of our own lack of knowledge that these misunderstandings occur. And that is why really having a culturally competent staff goes a long way to promoting safety, because people are less likely to be getting frustrated and annoyed or irritated or agitated, and you can put the adjectives in there yourself when we are, doing our best to understand where someone's coming from. Having our own emergency services department also helps. Thanks, Quentin. I bet it really does. I know at the hospital when I'm working, we have our own security staff. It helps a lot. We also have kind of a quick line to Providence. Providence police have a presence at our hospital on the weekends, but not during the week. And I was just having a conversation with staff that we wish the police were there every night of the week, not just the weekend, because at any given time, it can feel like the wild, wild west in the back of the emergency department. And I'm sure you all have similar experiences or know what I'm talking about. Respecting everyone's privacy. I don't know about you, but if you've ever had that experience of hearing someone's name yelled out, or just overhear staff talking about a patient, and it's within earshot of people who have no reason for needing to know that information. And so, it's pretty disrespectful to do that. Expecting the best from yourself. And I think I added when I did the pre-work video to also expect the best from your clients. If you are looking for what's good in them or the situation, you're going to find it. I always say to my kids, we always find what we're looking for in people. And if we want to find what's wrong, we're going to find that because it is basically what we're looking for. And I'm reading more. All right, so I saw it helps having emergency services. I participated in a great webinar on racial trauma and the other day, and they mentioned reducing issues simply by the things we hang on our walls, passively showing that your agency supports people of all backgrounds can lessen people's fears and stereotypes about BH care. So we hang things with the LGBTQ flag, things in multiple languages, diversity statements everywhere. That is wonderful, awesome. And I agree 100% that helps to create a sense of inclusion and that we're not turning people away. And even if we're ignorant, and, you know, I'll use that word because certainly it would apply to myself at times, that we're willing to expose our ignorance and just be open to learning more about whatever is important to our patients or our clients or residents, people who come to us for help. And then handling grievances thoroughly and promptly. If you are the first person who knows about a situation, that is the time to get involved. And if you're not the person who can answer the question or help with the problem, find someone who can. We're all responsible in whatever agencies we work at to be that person who doesn't just pass off, you know, to the next person. And it's a really important thing. And I know that if my job at wherever I am is nowhere related to whatever the person needs, it's okay. It doesn't matter. I work there. I'm an employee. I can figure out who I can at least defer to. And that really helps a person to feel valued and that we care about their issues and that we'll try to figure it out. All right. Before and during crisis, this was all covered in the pre-work. Behavioral warning signs. Who remembers any of those? How do we know when a person might be escalating to a point where we're going to have a crisis if it isn't apparent immediately? Just kind of a little quiz here to see what you guys remember. Delphine wrote having staff from various cultures, going back to the other, you know, the other slide. And Sherry wrote their stance for behavioral warning signs. I totally get the two, where the line just crossed from one topic to another. It's fine. And yeah, Delphine, having a culturally competent staff does mean that we make sure that our staff reflects the people who come through our doors. All right, Justice is here, and I think Justice is Yolanda or wait, Yolanda. Is Justice Yolanda? Does anyone remember who Justice is?
Yes, that's me.
Okay, thank you. The only person we don't have then is Megan, so I'm not quite sure, but I'll send something out to her just to let her know she can look at the recording. Back to Sherry saying their stance. Definitely, it's a sign. If you've got a person that looks like they're geared up and about to, you know, get in the octagon, hopefully some of you know what I mean by the octagon, or they're pacing or otherwise looking agitated, that would be a good time to see how we can help before, you know, something bad happens. And then Dan is saying a person's voice, their tone, lack of eye contact, or too much eye contact. Yeah, so you guys were paying attention. You get it. It's awesome. And then there's a whole lot of other things on here. Again, I don't want to reteach everything that you saw in the pre-work. My intent is to leave some time for you guys to try out a few exercises and that sort of thing. The person in control of himself, herself. And you can see here the tips and tricks and how we know How do you know when a person is in control of themselves? Have you yourself ever been in a situation where you felt like, oh my God, I'm going to lose it any second, or you are feeling agitated or frustrated? And think of a person who really got involved and showed calm and just had a demeanor of, wow, that person really helped me to de-escalate. Anyone have an experience that you remember, or that person who they just bring the calm to the table? Probably looking a lot like these tips and pointers here, relaxing their facial muscles. Monotonous tone of voice. I don't know how I really feel about that one. I think the point is, though, just not to raise your voice and not seem to have that high pitched or like you're not in control of yourself, kind of scared type of tone. People probably don't even realize it's happening, but just to be mindful of that tone of voice. And thank you, Dan already pointed that out. Removing your necktie, scarf, hanging jewelry. Again, we don't want weapons. We don't want anything to be available that will increase the chance that you're going to be harmed. Not to be defensive. Don't be argumentative. Don't respond to insults. All of these things already covered in the pre-work. Any questions about any of the last two slides on what it looks like and the recommendations for a person who's in control of themselves? I made a promise to myself I wasn't going to read everything twice to you, because I know I spent a lot of time on these in the pre-work video. The physical stance, good on, I forgot who said it. It might have been Sherry. I can't remember exactly. I'd have to bring the chat back up, but someone did remember the stance as well. And I'm going to go back. It was Sherry. All right. Very good. Even my own memory hasn't failed me tonight so far. Yay. But the night is young. Allowing that physical space between you. I might have sensed something about what people typically need between them. And amazingly, it's usually about, I want to say 8 to 10 feet. It's like it's a farther distance than we're doing right now with COVID. So it's actually beyond the 6-foot distance when we don't have a relationship with someone. That's usually people's comfort zone. And then standing at an angle, I'm sure I talked about that. We don't want you getting tipped over if somebody shoves you. And so that's why we say stand at an angle. So you can sidestep or not tip over as easy, right? If someone gives you a shove. All right. More on physical stance. I know I talked a lot about that already. The de-escalation discussion. You're going to get a chance to practice some of this in a couple of minutes. Give choices. That's really important. Wherever you have someone who's feeling powerlessness, or they're feeling that this situation can't get better, they're feeling hopeless about something, giving choices can really be a powerful tool that you can use. Even if it's just to say, you know, would you like to talk over here by these windows, or would you like to come, you know, over here outside my office? You know, whatever it is, wherever the choices really are that you can give them, just saying, where do you want to stand, kind of thing. Would you like to sit in this chair or that chair? As silly as it sounds, and I don't want to compare grown-ups to children, but you know, the rule when you're dealing with 2-year-olds and terrible twos. I can remember working for early intervention long time ago. I was a lot younger, but talking with parents about, you know, giving children choices such as, if they don't like what they're drinking, but that's what they have to drink, then saying, do you want it in the blue cup or the red cup? And that really can to help de-escalate a child. And so again, please don't misunderstand that I'm saying that we're comparing, but when we get in the kind of state that people are in when they are escalating, our primal nature is really in charge, and our critical thinking and our more adult mature control is not in the driver's seat when we're in that emotional state, that high emotional state. The prefrontal cortex, all of that, it's not working. The amygdala and all that other crazy stuff that's ruling our behavior at that moment in time, that's what's going on. So we just want to remember that. So when I bring up the toddler, it's because it's a primal stuff. And that's what we're trying to kind of tamp down so that critical thinking can get back in the driver's seat again. More on de-escalation. I forgot how many de-escalation slides we have. Don't solicit how a person is feeling or interpret feelings in any analytic way. This is not the time to say, so I think I hear you saying, because they're not in that, they're not in that mindset where they can really have those kind of conversations. Already talked about not arguing and not trying to tell them how to feel. And there's no content except trying to calmly bring the level of anger down to a safer place. So that is the whole purpose to de-escalation, is to bring down that level of anger to a place where you can have a conversation. You'll know when it happens. You'll also know quickly when it's out of control and you need to push that panic button that was mentioned earlier. And I forget, and I think it was somewhere in one of the slides that basically said you'll know within how many ever seconds. I think it was within 3 minutes. I think that's kind of what I'm remembering in my head. Okay. Just reading through here. You can read with me just to make sure that I understand in my mind what I talked about. So I'm pretty sure I pretty fully covered it all. Trust your instincts. Here you go. There's your 2 or 3 minutes, and follow your agency's crisis plan. If it's not working and you're really worried, and or if you know sooner than that, then don't wait. You want to go ahead and get in there and do what's necessary. There is a doctor, his name is Dr. Gavin D. Becker, D-E-B-E-C. Actually, I'm going to type it to you. Dr. Gavin D. Becker. I think that's his name. Oops, I sent it to Jolene. I meant to send it to everyone. Hold on. Everyone. There we go. He has a lot of pretty neat videos that are taped of him presenting to various agencies or I don't know, at seminars and that sort of thing. But he really talks about the difference between fear and anxiety, and then this whole thing about trusting your instinct. It's really quite fascinating. There's a video that's about an hour long, and I usually go in and pull out a few snippets, and I play it for a DCYF class that I teach. And really, I don't want to give it away in case you go and watch it, but there's some really neat things about intuition and listening to that inner voice and understanding that it's a protective factor that we all have. So if you do experience this sense of something's really wrong here, something bad's about to happen, listen to that voice. Okay. All right, so before we get into ethics, I'm going to stop the share and going to have everyone go into a breakout room. And what I want you to discuss, just everything that we talked about in terms of de-escalation. I want you to come up with one additional idea or thought for what you could do to increase safety for yourself, your client, and your agency. So one thing you can do to increase safety for yourself, your agency, and your client that we didn't already discuss. Does that sound okay? It doesn't have to be a million year conversation. Just a couple of minutes. And I'm going to go ahead and randomly put you in rooms and have you back in 5 minutes.
Get the clothes off the dryer. Get all folded.
So everyone's coming back now. All right. So that was either a quick 5 minutes or a long 5 minutes. I'm not quite sure which it was for you
A
all.
long 5 minutes.
Long? Okay. Was it hard to come up with ideas?
Yes.
All right. Well, and that was the purpose of the exercise, was because, sometimes we have these classes, but then when it comes to thinking about like our own safety and our agency's safety and trying to raise the bar a little bit and think about some ideas, I'm just curious what y'all came up with. So there were 3 breakout rooms, and there were a couple of people that weren't able to join at all. And so they may also have ideas, which I'm not going to put them on the spot, but if they want to add an idea, they can. Anyone from any one of the 3 groups, you wanna say what you came up with and share?
This is Linda. I'll say for the group that we were in, I will speak on the one that, like I had mentioned, was getting their family member involved, someone that they used as a, what was the word I used? As like a coping, not a coping skill. I forgot the word I used, but just having a family member involved and helping them de-escalate, someone that they trust and someone that
A supportive figure.
Yeah, somebody who's a supporter. That's a great idea. I know when there's a crisis in the hospital, like let's say we've got a young gunshot wound victim, and oftentimes we'll get like a horde of family and friends and people who come in, and rightly so, they're all very worried and they want information. But I will go and find that calm person. I will go and find that person who is the recognized voice of that family and that group. And I will work with them, because otherwise things can really get out of hand. So that is actually a method that can be really helpful. Thank you. What about one of the other groups?
Quentin and I talked about using respectful, clear boundaries.
Yeah.
So that way that can, so they're pretty much avoiding any conflicts between the staff and patients and the agency in the whole.
Okay.
And he also mentioned something about how you set up your office so you can be able to get out quicker if anything happens.
Yes. And there are so many of us who are in offices where there's literally one way in and one way out. And it's tough. So you do want to be mindful of like, where are you in relation to that door? Give yourself as much of an out as possible, but also having those clear boundaries, which we're going to go into ethics and boundaries shortly. And it's something that is going to help to have the client know what to expect from you And that gives them that feeling of stability. So good, good, good. I think there was one more group.
That was me.
Hey, Sherry. All right. So
Hi.
it's okay. No pressure, because I know you said it was a long 5 minutes trying to think of something, but I'm sure you guys talked about something. Feel free.
Well, we talked about how I work in a group home, and I think Dee was with me and Trent.
Okay.
And she also works in a group home. And it just seemed like we all have the trainings that we go through. And there wasn't like an additional thing to add to what we already do, that anyway that I could come
Okay.
up with.
That's
so-
fair enough, because we did give you a lot of information, and I will make a suggestion, such as this. If you have safety committees, or you have people who you can float your ideas through that have something to do with policies or safety policies, if you will, getting involved in that kind of thing can also be helpful, because a lot of times the people who are writing those policies are administrators who aren't the ones who have the day-to-day face-to-face interactions. I'm getting some head shaking here. And so they're a little bit too far removed to think of all the stuff that you guys would think of in terms of, hey, what would help, what would keep us safe, what would keep our clients safe, what's a really good way that, we could have some certain things written in policy that would help out. So just being involved is way more valuable than you realize, because you guys are the ones with the information. You are the ones that have the good ideas, and you're also the ones that know what can happen when you talk about office space and just the different things that occur that might increase a person's agitation, such as having policies that you're booking 10 clients in a 3 clients slot, because you have kind of a tendency to have a lot of no-shows or something, so you just overbook a lot, and then sometimes people come in and have to wait an hour. Now they're an hour late, and then you wonder why they're already in a bad mood and kind of foul before they even get through the door of your office. I'm not saying that's happening. I'm just giving that as an example of some policies that we could look at to try to decrease the chance that folks will be struggling. All right, I'm going to go back and get ethics. And I do see that I think I have a new chat, which I'm going to look at really quick. And let me get to the bottom. Nope, we're good. I don't know. I think I just must have had to let someone back in. Perhaps they got shut out. So we're going to talk about ethics, which someone already talked about in Quentin's group. And was it Delphine? Delphine, were you with Quentin?
Yes, I was.
Okay. So you guys already talked about kind of clear boundaries and all of that. And it's really a good idea. So the ethical dilemma, there's 3 conditions. They all have to be a part of this condition in order for it to be called a dilemma. So there has to be someone who has something to decide. There has to be more than one course of action, and no matter which course of action, there's going to be some ethical principle is compromised. I think I gave you guys an example during the training that kind of talked about someone drowning maybe, and that, I can jump in and maybe we both drown, or I can do nothing and call for do nothing, or I can call for help and wait, and the person might drown while waiting. I could go try to get something and throw them a lifeline. Like, you have all these choices, and kind of gave that example as an ethical dilemma. But I suspect that you all have examples in your workplace of ethical dilemmas that you run into from time to time. And I'll give you a chance to talk about those or, amongst each other shortly. But just a reminder, the Medical Assistant Code of Ethics. Now, I don't know if for you all, if that is the code of ethics that you subscribe to, or if you have another code of ethics for your own workplace. Do you guys use the Medical Assistant Code of Ethics, or do you use a different one? Do you know?
Well, I don't know. I'm in school as well. So in studying counseling, of course, we use the counseling
Okay, yeah. So if
and the one for social workers, and they're all kind of similar, actually.
Okay, they really are very similar. I know for me and DCYF and at the hospital, the Department of Clinical Social Work, we use the National Association of Social Work Code of Ethics. But they are very similar. They're similar to the medical profession code of ethics as well. That whole idea of not doing any harm and the right to self-determination in clients, that sort of thing. And it also talks about our own behavior and what's expected of us. So Quentin wrote that they use the counseling one too. But for the Medical Assistant Code of Ethics, I think it is arguably similar to whatever code of ethics you're using. Oops, what did I do? I just made the chat really big, so I lost my slide. But basically being respectful of our clients and keeping in mind confidentiality and the importance of that, and not talking to people unless it's, either duty to warn or right to know or need to know, or a person gives us a release, whatever the rules are in our agency around who we can talk to. Sometimes we don't need them if we have contracts and partnerships, then we don't have to get releases. For instance, I keep talking about the hospital because it's just the easiest example to use and probably the closest to the work that you all do. But in the hospital, we have a contract with the Institute for the Study and Practice of Nonviolence. And anytime there is a community violence incident, a stabbing, a shooting, someone is a victim of a serious assault, we can call them on behalf of the client without the client saying that they want that call to be made. And so that's just an example of where we would be able to make a call without the client. But ordinarily we would get releases of information before we would talk to various people. And then upholding the honor and high principles of the profession, seeking to improve knowledge. And I think that's across the board. Most all of us have licensing requirements too for certain professions. You get to the point where you become licensed, and then there's an understanding that you're going to keep up on the latest techniques or knowledge for that particular profession that you're in. And that you're not going to just say, well, what I know today is what I know, and this is how I'm going to practice for the next 30 years. We have to keep up on things as they change. For instance, when I went through school, there was no such thing as telehealth or telemedicine. The idea of having a counseling session via Zoom would have been ludicrous and ridiculous. But now we have a whole chapter or area that discusses, and make no mistake, this is new territory, but we are now being forced to really come to grips and terms with how do we adhere to our principles, our code of ethics, using a Zoom platform. And so, but that's all part of progressing and staying with the times, and it's going to be more acceptable for some people to have appointments that way. And I can think of some clients who would definitely prefer to have that be their method. Maybe someone who's really lives out in the boondocks and transportation is such an issue for them, but they really get something out of talking to people and it helps them, would benefit from kind of a Zoom platform, if you will. And then participating in additional activities towards improving the health and well-being of the community. And so that could really be showing your involvement in any number of ways. Being a part of committees that I talked about earlier that promote the safety and well-being of your clients, or that have to do with getting resources, if you will, to help those clients. So a lot of different things you can participate in, but that's the code of ethics. And like we discussed already, they're quite similar. But it's important, whatever your licensing body is, that you make sure that you know your own profession's code of ethics, especially if you're licensed, because if you don't want to be making mistakes of the ethical type, you'll really get yourself in hot water and lose your license. So it's something to be careful of. Relevant principles. There's more principles. Obviously, I picked 3, 5, and 6. Well, I didn't. The people who wrote this curriculum did, as being most relevant to the behavioral health content of, this whole training program. So just making sure that we're accurate, truthful, complete in communications, direct or indirect. When we're documenting, that we document what happened, that we don't put in there anything that we don't say we did something and we didn't, kind of thing. Certificants shall not engage in behavior or conduct that's lawful or otherwise that causes them to be perceived to be a threat or potential threat to privacy, health, and well-being or safety of recipients of certified medical assisting services. Now, no one here is a certified medical assistant. Am I right about that? We don't have any medical assistants in this group, do we? But you can fill that blank in with, I think most other professions would have similar expectations. We shouldn't engage in medical assisting while our ability to practice impaired. So that basically means we're not drinking or drugging or otherwise under the influence of anything while we're practicing. And I don't believe that is just for medical assistants. That would be for any of us who are in a position of working with patients or clients or residents, whatever we refer to our the people we serve. Any questions about that piece on ethics? I know it was a lot. It was a little bit of a recap there, but ethics is pretty important. So I want to make sure that I didn't go too fast, hopefully. All right. What I'd like you to do right now, there's the core values. Ethics case study. Rather than actually look at an ethics case study, what I want you to do is I want you to have a 5-minute conversation with each other about an ethical dilemma, and then talk about how you resolve that. And if it's not an ethical dilemma that you experienced, maybe it's one that you know about at work, that someone else had an ethical dilemma. Or perhaps you know of something that is an ethical dilemma you're not sure to tell or not to tell. You don't have to give me all the details when you come back. I just want you to have this conversation with each other so that you get a sense of what other people are experiencing around ethical dilemmas. Okay, I am going to pause our video for a minute. Just invited folks to come back. They should be back in about 30 seconds. If you were not able to join the breakout room, hopefully someone will share their ethical dilemma and tell us what they came up with.
Oh, shoot.
All right, we still have about 4 people coming back. There we go. Everyone's back now. So I don't know who wants to share or not, but just wondering what you talked about, or as much as you want to say or not, understanding that this can be a little bit of a challenging conversation. But anyone want to share an ethical dilemma and a resolution if you came up with one?
Sure.
Okay.
So what I was talking about in my group was I had this client a few months ago, and I was working as his case manager. So one of our responsibilities is to take them back and forth to medical appointments as like an emotional support person and someone to help them kind of understand the doctor's orders and things like that. So this client was pretty intensely cognitively challenged. He was having a lot of memory issues and just really not taking his regular medications as prescribed. But he was also in the middle of being diagnosed and treated for lung cancer.
Oh, gosh.
So we ran into this really difficult situation in which he was a recent widower, and the person helping take care of him was his sister. But she was unable to make it to these oncology appointments because she didn't have a car. In my agency, we're only allowed to transport the client, so I was not able to take the sister to these oncology appointments as his emotional support and the person who's helping him with his daily living stuff. And it really didn't sit well with me because I feel like she really should have been there for those. So my issue was, do I just continue to take this guy because he needs to go to these appointments, obviously? Or do we make the choice to have him and his sister take MTM together, which would get them both there, but then I wouldn't be there? But a problem with that is that MTM is super unreliable. So if we make the choice to make sure that the sister gets there, the client might not get there because MTM might not show up.
Oh, God. Yes.
It was really sticky and challenging and just super uncomfortable. And I ended up, unfortunately, having to come to the compromise of I physically bring the client, and then we called the sister from the doctor's office and kind of put her on speaker so that she could still hear what the doctor was saying and all that.
Do you want some? It's hard. Chicken nuggets. They're good though, but I made them really hard.
So it was better than nothing, but still not as great as having his sister there as that emotional support and all of that.
Oh no, I still have thing in my thing.
Dee, I think your speaker's on.
Oh,
That's okay.
I'm so sorry. I'm still out walking.
That's
Sorry.
okay. That's all right. We understand lives are going on while people are zooming from home. So Quentin, that sounds like a really good compromise. You made the best of a bad situation, in that it would have been ideal if you could have transported the sister too. Then you all could be there, but certainly having her at least there by phone. And I think there's a lot of that going on now. You'd be surprised. And we have doctors talking with patients about end of life care by phone because of COVID.
Yeah, unfortunately, this was before COVID, so that wasn't quite normal yet.
Yeah.
This was probably about a year ago at this point that we were doing that, but
So very
yeah, I think it
creative.
probably would have gone over better had people been used to it with COVID.
Yeah.
But there was such an issue with like liability of transporting her and then making sure he actually got to these appointments, and
Mhm.
it was such a mess.
And MTM, have they gotten any better?
No.
I asked because I had someone call me from the Chapman Clinic, and I don't know if you're familiar with the Chapman Clinic, but it's a lifespan clinic that's part of the hospital, and a lot of patients go there for their primary health, primary care.
Mhm.
And I got a call at like 9 o'clock at night saying that a patient is there still waiting for their MTM person to pick them up, and the clinic had been closed since like 7 o'clock. Can I help? And it was like, oh my gosh, well, I don't know. But as it turned out, someone called an Uber and they were able to get home. But MTM, and
They're
that in and of itself is quite a problematic thing that I think can cause some dilemmas. And the ethical dilemma of having that patient that you're describing have to choose between getting a ride and going with this provider or having his sister who's his support system there. I mean, it really put you in a crazy predicament. But then again, you can see where that was a dilemma because there's no perfect answer either way. And so that's why there was a choice to be made. And oftentimes we make the choice that seems to do the less harm or that we're going to get the best outcome, I guess, from. And even though it's not a perfect outcome, sounds like you came up with a good plan. So don't be too hard on yourself. I mean, you're working within a system where we don't always have the ability to have, things be perfectly the way we want them to be. But it's definitely not comfortable. I don't know what we could do from a policy perspective, or if we could, talk to someone about MTM and MTM's rules and allowing a support person for certain people and all that. But, or I'm sorry, not MTM, your agency around allowing a support person. That would probably involve a lot of, conversations with who do I have to talk to? How can we make this happen and all that? And I'm not suggesting you should do it, but I'm just saying maybe down the road someday that might be, especially if you stay where you are and you get in a position where you have more control and power and authority, you may very well remember this and say, let's fix this policy.
Yeah, and at the very least, it could be a conversation about, hey, can we have this person sign an authorization or a release or whatever so that we're not held liable in this one situation that we have to deal with this,
Yep. Or how much extra would it cost to put a support person in our policy, as we will also transport like one support person or something like that? Would it really cost that much more? I bet if they asked the insurance company, it probably wouldn't be all that much more, but who knows? Not something I really am knowledgeable about, so I probably shouldn't say any more about it. Thank you for that. How about other people? And again, as I said, you don't have to, but I just don't want to skip over if anyone really has a dilemma they want to share. I'll give it the normal pause.
I shared a dilemma with my group. It was a little different than what Quentin had kind of shared, like a different type.
Yeah.
But it was more to do with like the client on client interaction maybe, and like more so the conversation and kind of like an example from my own home is I have a client, who reads a lot and likes to use his computer to look up a lot. And of course we support, and embrace, studying and learning as much as you can about anything, whether we agree with your take on, a bunch of different topics, that are very controversial throughout the whole world, never mind just this group home. But the problem, of course, becomes that we have a couple of different clients who maybe fit those categories that are sometimes controversial. And then it's like this one client who does a lot of his reading maybe walks around and kind of says a thing here, says a thing there. And although, of course, it's support of freedom of speech, it's more so like, well, we don't want you at the dinner table, talking about your take on this when we have a client who's experienced this a lot in their life. That's maybe one of their traumas already. We don't need you bringing that up, whether you're right or you're wrong, or, you're that kind of deal. And it kind of deals with, okay, we can always address it and have him come to the office, and maybe all the staff can tell him, look, it doesn't mean that anybody is going to say that you're wrong for thinking the way you do, but you can't ruin, this lady's dinner or this gentleman's dinner, just to share your take on something at a pivotal time in the night. So we kind of talked about that, I guess, a little different, but.
Well, you know what, Trent, it's still a bit of a dilemma, because on one hand, you've got the rights of one client, and then you've got the rights of another client. And if they're not, like, if one feels like they're being harmed by the other, then yeah, it is a bit of a sticky wicket. But it sounds as though protecting the folks who don't want to hear about it, and having that person understand that they've got to respect the rights of others as well.
Right. Right.
I mean, it doesn't sound like you violated his right in any way, because he just has to pick and choose a different forum, because the dinner table, where a person has no choice, like they have to be there, that's where dinner's served.
Yeah, exactly right.
Then it isn't the time and place for whatever that person was sharing. I won't ask, because it sounds like something that was probably very unpleasant.
Right. And I guess it's not as much so as the unpleasant, like if it's unpleasant, but it's just so many, there's a side and take for every controversy, like in the world, and then it's like, of course, the ones that are, very serious really have caused trauma in some of these people's lives. So that's kind of the big thing. Like he doesn't have any idea what the other, 12 people, 11 people in the house have dealt with, or like the person sitting right next to him could be like the most, anti side that he's preaching at the dinner table, without getting too deep into it. That's just how it is. And that's life in general, but still, of course, a time and place for everything. And it's just he's there for a reason, and that's why he's got to eat at that dinner table, and she's there for a reason, and that's why she has to eat at the same dinner table, and that's all you can really say.
Yeah, and protecting folks from being re-traumatized,
Right.
especially when their clinical history. It sounded like what you had to do, and
Right.
you could justify your placing limits on him, even though it felt a little bit like a dilemma. But yeah, what do you do? I mean, there's this kind of stuff happens all the time. I'm sitting in, I'll tell you guys a quick story. I was sitting in my office one evening, and there was a gentleman who was with his caretaker, who was the professional who was with him, brought him to the hospital. And this guy the patient was yelling out obscenities, racial slurs. And I'm sitting in my office feeling super uncomfortable now. And I'm like, what do I do? Should I go out? I should go out. I need to go out. I need to say something. Like, I should stop this guy. Like, what, maybe we should call security. And so I walk out in the hall though, and the guy is the professional who the patient is yelling terrible things to. He says to me, goes, the guy has Tourette's. I'm used to it. I'm his caretaker. But at the same time, that we have all kinds of people in the hospital that don't know the story. And this man is like screaming racial slurs. It was really horribly uncomfortable and quite a dilemma. And I'm like, I said to discharge, I'm like, can we like get their transport? Can we get them out of here as soon as possible? Because we have all kinds of patients that are hearing this that are probably being, just like you said, traumatized.
Right.
And it wasn't the guy's fault. Apparently it was part of his mental illness, and he couldn't stop saying it was like a Tourette's kind of thing. But it really did create a bit of a dilemma in that moment, because I felt like he was creating an unsafe environment for other people.
Right.
For the same reasons that you were talking about. But that's what it made me think of. And I'm like, oh my gosh. But I was actually relieved to hear that it was a gentleman who couldn't help himself, because otherwise I would have just felt horrible.
Right.
What in the world is, what should I do? It was just really bad. But all right. Thank you for sharing yours. And were there any others? Again, I just don't want to skip over anyone who has a burning desire.
I had mentioned with my group about a time when I worked with I was working with children, I work with youth, I worked with different, almost every population. But I had a situation where I knew that I was supposed to contact DCYF because of what had been disclosed to me. And I was really finding it so challenging because I had saw the children, they was very attached to their parent, and it was really, really challenging. And but I believe the National Board for Certified Counselors, their code of ethics says that a counselor seeks out consultation or supervision from, when they don't know necessarily what to do or is facing a challenge. So that was one of the examples I used.
Okay, good. And what ended up happening? Did you end up having to call or you didn't have to call?
Well, yes, they had to be called because I still had to put the safety of the children first, and counselors are mandated reporters. But I did just seek out the supervision of my supervisor because I found myself being challenged. Like, honestly, it was challenging and it became an ethical dilemma because I had to make that decision. And I sought out supervision from my supervisor.
Yeah, and especially Yolanda, I can relate to the part where you have a relationship with that parent and you're also thinking, oh, is this call going to somehow set us back in terms of our trust and that parent, talking to me kind of thing too.
Yeah.
But a lot of times when parents understand that a mandated call is really beneficial for everyone because you care about their situation and getting them the help that they need. A lot of times they'll understand. Or if we've said to them, we have to call and here's why I have to call, and they're explained. I always recommend that if you have a therapeutic relationship with a client and you have to make a call, that you definitely let them know that you have made the call. Unless it's something that's going on right now and you feel like the kid's in danger and you don't want to alert someone, then you wouldn't tell them, because obviously you want someone to get in there and rescue the kiddos if there's like a real present danger going on. You don't want to alert anyone so they go and hide the kid under the bed or something.
Yeah.
But thank you for that one. And I think that's a more common one than people realize is that whole mandated reporter world that we get into when we're working with youth, families. It can be adults or children, because if an adult tells you something, then and they have children, you have to call, or if the child tells you same thing. So it can be challenging because you're sitting there thinking, oh God, why did you tell me that? Because now I really do have to make a call. So it's tough.
Yeah, there's sometimes, I'm sorry.
No, go ahead, Dan.
Yeah, there's sometimes like I hated the mandated reporter aspect of it, but you say it up front. I'm thinking Crossroads. I brought that up in the group I was in. But you had like 15 rooms with families in there. Like, for an example, like there could be a night where there was a fire and you have a family of 5 squished into one of those rooms. This is before, I guess it's huge. It's bigger now. Like the family center, not 160 Broad, but
okay,
where I forget what street that is. But anyway. So you would have them together, and this is before all this was happening, where now you're starting to hear about a lot more child abuse and everything else going on right now, because families are in the house 24/7 with each other, and it's kind of the same thing. They were in the room with each other, and then you would hear a smack or something like that, or the kid would get. It would be a situation where you have the teenager who says, I'm old enough to be able to go out on my own, but you can't. You have to be around. One of the rules I remember from there was that children must be in the vision of the parents at all times. So you can only imagine what like a powder keg that was setting up. And is so you'd have a kid wandering and they would come up and whack the kid and
Yeah, you have to
they're in
call
that
that.
situation.
I'm sorry about that. And it is true that that's one of our sticky wickets in this field is the stuff that we have to report on. And, you know, and hope at the end of the day that the family received services and that it actually helped them out in the long run. So, you know, usually I think that is oftentimes what the outcome will be. So, all right. Now it is 6:25 and I think you guys need to take a break. So I'd like you to, hold on, I'm going to pause there we go. All right. So it is important to understand though boundary crossings and what that means. And those are those red flag behaviors that we talked about as well. And so there are kind of like a minor infraction, and then there's the really serious, you're on a slippery slope, and you could really get yourself into some trouble kind of behaviors. Unfortunately, though, what happens is if you've got these boundary crossings happen, it's almost like kind of people start to slip and they don't even realize it, and then suddenly you're in a dilemma. Or you've got yourself into something, if you will, with a patient around what their expectations are because of some of these boundary crossings. And so it, you know, it can happen to anyone. Did I tell a story during the recording about working with a patient when I was an early intervention worker, and I had a mom who had a little boy who was involved with DCYF. It was a very traumatic case. It was you know, it was a child abuse case, and this mom had really become pretty reliant on me as her main source of support because she had felt as though DCYF was being unfair to her and her spouse. Now, I wasn't working for DCYF, I was working for early intervention, but towards the end of my time with this patient, it became clear to me that I must have inadvertently given some signals that made our relationship unclear to the client, because when I was getting ready to end or do, you know, terminate our relationship, the mom said, "Oh, I'm so happy you're leaving now. That means we can be friends." She had this like Christmas present thing that she made me that had my name all engraved on it. And I was just beside myself. There I'm sitting, I'm a brand new worker. I've just graduated with my like Bachelor of Social Work, like years and years and years ago. And I'm sitting there saying, oh my gosh, what am I going to do? She bought me a present. She thinks we're going to be friends. And like, what am I supposed to say? And I really felt badly for her because I know that everything that she had been through was completely horrific. And her child went from being this little boy who was developmentally on target with all milestones, like he was walking and everything, and now he's a little boy who won't ever sit up and won't ever walk and probably won't talk. I mean, it was just a terrible, terrible, tragic thing that she went through, and I was there at the very beginning and for months was working with her. And so when it, like I said, when it came time for termination, now I had to deal with the fallout of not making our relationship clear enough over time. Does that make sense to people, like what I'm saying, how we got there? I'm not quite sure if I actually had to pinpoint, other than I think my advice that I would give my younger self would be to be frequently visiting those boundaries and making sure that the client understood my role and that we couldn't be friends. And so, you know, it was really hard and uncomfortable and awkward, and I paid the price for it myself as a professional because I had to now explain that at the worst possible time because it's our last visit together and I'm literally leaving her, and I established a place in her life that I shouldn't have been playing that role. If I had realized earlier that she was depending on me the way she was, I should have been working on enhancing her own support group rather than allowing her to depend on me in that way. Do you guys kind of feel that pain around what I'm saying as far as, you know, you might see that happening in some of your own interactions with clients? But I just use that as an example because it's probably one of the worst ones that I have in my own, you know, my own career and memory. That was like my very first, oh boy, I really stepped in it moments. We all have them. I'm not judging anyone. I don't think any of us get through this type of work without having those, oh my God, I stepped in it moments. That's what I'm going to call it. I don't know. You can call it what you want. Boundary crossings, they're calling them here. Any thoughts? I know I just told you a big, long, drawn out story.
No thoughts.
No thoughts? All right. Not a worry. But you kind of know what it means. And then
Yeah.
there are boundary violations, which are a little bit different from boundary crossings. Because for the situation that I described, the crossing was not corrected, or I didn't backtrack, or I didn't make the relationship clear enough, just by evidence or as evidenced by what happened. Because, you know, looking at it now, many years ago, I can clearly see what I might have done. If I were my own supervisor, you know, I would have had a lot of good things to say. But back then, you know, I didn't know what I didn't know. But boundary violations are different. We're in a different territory now. These are things that are characterized by excessive personal disclosure or secrecy, or even a reversal of roles where the professional is getting some sort of support and emotional satisfaction or something out of that exchange that happens between them and the client or a patient. So violations can cause distress for the patient and or not be recognized or felt by the patient until harmful consequences occur. And so this is well worth repeating because we want to make sure that we're not in this boundary violation area. I'm going to tell you that crossings can lead to violations. Usually crossings are well-meaning. Most folks who are in that boundary crossing territory, oftentimes it maybe is something that isn't said, or we don't respond to something a person says because maybe we don't want to hurt their feelings, kind of thing. That's how the boundary crossings occur. And then an example here, they talk about a professional's use of social media might be another way that we can unintentionally blur the lines. And so anytime that we post anything that would give away someone's information or otherwise talk about a professional interaction that we're having at work, like it would really not be appropriate. So, you know, when I talk to you about things that happen with me at work, I'm as careful as I can be not to give you any identifying information. Try to keep it as generic as possible. But if I were to start giving you names or giving you details that you could actually guess who it is, that would be a problem. That would be a breach of patient confidentiality, and that would be a boundary violation for me, even though I'm in a professional setting right now doing this with you. Does that make sense? Okay. Self-disclosure exercise. I'm looking to see if I have the example for that. I'm actually looking for it in my book right now because I'm like, oh, I don't remember the self-disclosure exercise. I didn't have that listed as something I was going to do tonight, but that doesn't mean we're not going to do it. It just means I'm going to look for it in my book. And if I don't find it, we're going to skip it and we're just going to talk a little bit more about boundaries, which I think is what we're going to do rather than, because I do have a couple of good things, nice things that I have set up for tonight. But self-disclosure, if you were to have, I'm going to do this as a discussion for all of us because I've got two people who can't go into breakout rooms. If you were to have a dilemma where a person says to you, and I'm going to give you a common dilemma that we find around boundaries. You get to know a client, a patient, whoever you're working with, and they continually ask you about personal things about yourself. Oh, do you have children? Oh, where do you live? What do you do for fun? You know, just kind of small talk a lot, but it gets to the point where you're starting to feel uncomfortable. So what I want us to talk about, actually, if everyone can chat something that you would do in response to someone attempting to encourage your self-disclosure as a professional. So I'm going to open up my chat so I can see it. And then as people have ideas as far as how would you address it when a person is asking you a lot of personal details, and I'll put one of my own in there too, just so you can see it. I'm gonna write. And then I'll go over our responses. So we should have 13 or 14. We should end up with 12 responses or 13 because one person is sharing. So whoever is sharing with Linda, I think it is, go ahead and just like write 2 things and we'll kind of review them together. All right, I'm going to start reading people's responses. One person writes, I say, oops, as people type in, my whole thing like jumps up. So I have to pull it back down to see it. I wrote, why do you ask? Sometimes figuring out why a person wants that information just leads them to kind of say to me what it is that they really want to know. So for instance, as a DCYF worker, I would often have families, parents say, do you have children? That was like a common thing. And I'd be like, well, why do you ask? And oftentimes they would give me an answer such as, well, I just want to know if you have any idea what it's like to be a parent, kind of thing. So, you know, sometimes if that's the reason they give me, I would say, I understand what it's like to be a parent. Yes, I am a parent. So I don't go into detail. I don't talk about my children, how many children I have, the ages of my children, anything like that. Sometimes, though, there are therapeutic reasons why self-disclosure might be helpful, and we'll talk about that next. Carrie writes, I say, let's continue focusing on you. Redirect the conversation. Yes, that's another way that folks could handle it. That is commonly, especially in supervision, it's like when we start to talk about how do you redirect people, like what are some ways to do that? Sherry, I turn the question back to them, similar to Carrie's answer. Yolanda writes, it's not about me, we're here for you. I like it, a lot of redirecting, like you guys, I can tell you're in the profession that you are. Delphine, I can't discuss that now. Let's get back to you. And Stacy, definitely try to redirect back to them. Quentin, depends on the environment in the clinic. I would be more likely to give a little bit more information and then say, we're not here to talk about me, let's talk about you. If it's in a group home, I'd likely be much more direct and say that it's not a topic we can talk about. As a staff member, like we don't talk about ourselves. All right. And a lot of the same redirection rather. And I just want to check. There we go. Jolene says, I do tell clients that it's not an appropriate conversation and we can talk about something we can all talk about. All right. And then Linda, when I was at the children's program, I was told to say to them, how will it benefit you by knowing that information? Yeah, that's another interesting thoughtful way of redirecting and also getting them to kind of divulge a little bit more about why do they want to know and how's it going to help them. I love that one. I'm going to steal some of your answers here. They're all good. I give a vague answer. How old are you, Trent? Old enough, Mr. Blank. That's a good one. Old enough. So kind of making it a jokey thing. So that's cool. And then Dan, I try to set that up at the foundation. So you kind of let them know what some of those boundaries are and the things that we will and won't talk about. I understand your curiosity about me. It's perfectly normal. We have a relationship, a professional relationship, and it's normal to be curious. Just understand that I would never want to do anything or say anything that puts me in a less than professional stance with you. And so your therapy is way too important to me for me to start making it about myself, and I'm not going to do that. Dee says that's personal and not appropriate in this setting, so let's get back to you. All right. So y'all know you've been doing this a long time, and obviously you know your way around that type of dilemma. So now what I'm going to do is see boundaries in medicine. I'm pretty sure I talked about this, but there's a source here that I used that you can copy and open it up. It's a PDF, and it talks for anybody who's in any kind of medical setting that they need to examine boundary crossings, be aware of the implications, and avoid repeated crossings. These are the kind of things that you want to talk about in supervision with your supervisor. I don't know if y'all remember from school doing anything like process recordings or other similar kind of exercises where you write down the client said this and I said that, and the client was probably feeling this and I was feeling that, and like you kind of journal and write all this, and then you take it to supervision and you talk it all out. When I was a student, we did that kind of stuff. I'm not sure for counseling if you do similar things. I'm assuming that you probably do. But that's often where you first have the experience of discovering that, oh my God, I had a boundary crossing. It's a really good thing to be open and honest about these things with yourself, and always be mindful of, why am I having this conversation? Or if something feels weird, all of a sudden you feel like, oh my God, I think I stepped over a line, just kind of, figure out what you need to do to step yourself back a little bit. I can tell you, I'll give you another, boy, you're going to be like, what is wrong with this girl? She's got so many stories of terrible things. This wasn't such a terrible thing, but I have to say, I'll give you a story in the hospital where there was this guy. He was a Navy chaplain. He retired years ago. And he came in the hospital and he had lost one of his children. And it was tragic. It was not a good story at all. It wasn't expected. It was just really a tragic situation. And this fellow comes in and just like a sweet chaplain kind of guy. And at the end of the day, like when he was about to go home with his family, he stopped and started trying to counsel me and ask me how I was doing. And I was so like moved by that. I'm like, here's this guy who just lost like a really important person in his life, and he is genuinely worried about how I'm doing. Like I had to hold back the tears. Like literally I had tears in my eyes and I was fighting it. And he's just like, "Can I give you a hug?" And I'm like, "Holy crap, mega boundary crossing. Now he wants to give me a hug." But I'm like, the guy's 85. I'm going to let him give me a hug because I think he needed it anyway. And but it's just these kind of things that happen and you stop and self-reflect. And it was just like, wow, like this is just the human nature of the work that we do. And always, it's almost annoying sometimes that we have to stop and pick things apart and think about, is that professional? Is that unprofessional? Did I do the right thing? Didn't I do the right thing? Well, you can bet when I had supervision, I brought that story and my supervisor was fine with what happened. It wasn't an issue. But, understanding that you always have, and at least I hope you do you guys have channels or outlets and supervision available to you in your agency, people that you can talk to about these kind of things, or at least peers that you can bounce this kind of stuff off? I'm not seeing head shaking, but again, I don't have my gallery. I'm opening my gallery so I can see some faces. Okay, do you guys do supervision where you work? Yeah, I see some head shaking. So, I would suggest, it's really helpful. I'm a believer in peer supervision. I really like, and I'm hearing some yeses now, that whole idea of when we're not sure. These are the folks that can really help us out and also be a sanity check for us, especially if you're questioning something you said or did and it's like, what was that all about? Like, is that an emotional reaction I'm having to something in my own history, or is that just in the moment and I was having compassion or empathy for this person? Like, I don't know. I hope you guys will be comfortable doing the whole self-check thing with peers or yourself if that's all you got. But I would always do a temperature check or a self-check around these kind of things. It lives in the same wheelhouse as self-care, professional well-being, making sure that our boundaries are staying where they need to be, because we're complex human beings and we're gonna sometimes be a little scattered in all these areas because of the nature of the work that we're involved in. Like a lot of times it's just like human tragedy that you're experiencing and witnessing when you talk about secondary trauma and all of that kind of stuff. Like you guys are all susceptible to those kind of things. Any comments about that? I'm going to go past the medicine and actually leave it right at the red flag behaviors. Too many stories? Am I telling too many? No one's answering me. I am going to say that I just appreciate that. I know the hard work that you all do. I'm not exactly in the agency that you are in, but I work with some of the same people that you do. So I understand that it can be really difficult and that you're exposed to a lot. And it's important that we take care of ourselves. And that's why I left self-care for last. And it was the thing I wanted to spend our last like 20 minutes on before kicking you free to work on your presentations. Did I show you the presentation sample in the first week or two? Any no's or yeses? Did
I think you
all-
did.
Yes.
Okay, good. I was just going to say, did you all leave me? You're all watching the news right now.
Yeah.
So red flag behaviors, there's a laundry list right there. And I think it's pretty self-explanatory, but in case there's any question that any of those bullets down there would be considered red flag behaviors. These are violations, discussing intimate or personal issues with a patient. This goes beyond boundary crossing, and this is really where you start to get into that danger territory, like losing your job, causing harm to yourself or to your patient. So you really want to be careful. Anything that could be interpreted as flirting, keeping secrets, some of the same stuff I said earlier. Believing you're the only one who truly understands or can help the patient. That one right there, I would almost highlight. We have to understand and realize that we're so temporary in this person's life. We can't have them depending on us or setting it up so that this kind of thing happens. I told that story of the woman I worked with when I was with early intervention. I don't think that I really was sending the strong signals that I was the only one who truly understood. I just think I was so heavy on empathy and I was so new to the field. And she was going through such a traumatic issue that she didn't think she could share with anyone else because, no one in the family wanted to hear how much she still cared about her spouse who had abused their child. And she didn't, I think, have a lot of family members who were showing her any kind of listening ear about that kind of thing. And so, in retrospect, I would have set her up with a counselor or someone else to talk to. That wasn't my role. I was there for her child. I was her child's early intervention worker. I was there clearly to help around his developmental needs, but not so much to be her emotional supporter. That's only a small part of the job. But looking at that bullet right there, if I had really felt that I was the only one who understood, that would have been a huge violation. I just didn't know that she was thinking that. And I had no insight on that until it was too late. Spending more time than is necessary with a particular patient, speaking poorly about colleagues or your employment setting. That one's hard sometimes, but I can't tell you how many times I've walked down halls and I've heard employees talking unfavorably about where they work. And it makes me think they're very unprofessional. I mean, I don't know if you've had it happen, but you got to realize that people are around. And I'm not suggesting any of you do it. I'm just saying that it's just be mindful. We don't know who's around, and we are a reflection of our agency, and we want to be careful. And if it is so problematic, that maybe we should spend some of our energy and effort on how can we make it a better place instead of, bashing people and kind of giving us a bad name and ourselves a bad name at the same time. Showing favoritism. Oh, Mr. So-and-so, someone called someone Mr. Blank. Oh, Mr. Blank, you're here. Let's get you right in. When poor Mr. X blank, another blank, was waiting so much longer. And, people notice that kind of thing. Meeting a patient in settings besides those used to provide direct patient care or when you're not at work. So those are pretty easy examples. I don't think there are questions, but I'm going to ask you anyway, whether or not you guys feel that you have a grip on what red flag behaviors are, what boundary violations are. Or do you have questions? If you have questions, this would be a really good time to ask about the boundaries. All right. So with that said, we have about 20 minutes, 5 of which I want to do a meditation with you guys at the end. So I'm going to make sure I leave us enough time.
nice.
Go ahead.
No, I say, oh, nice.
Oh, good. Okay.
Yeah.
Aspects of who we are. So there's this thing called the balance wheel. And in the balance wheel, and I think you have it in your books, there might be a handout called the balance wheel, but it is in the handouts in PowerPoint if you, or I'm sorry, in Google Classroom if you need it. Social, emotional, intellectual, physical, spiritual, occupational. These are all aspects of who we are. And the idea behind the balance wheel is that we want satisfying amounts of each of these things so that our balance wheel isn't off kilter towards one thing or another, that we want to be well-rounded and pay attention to all of the aspects of ourselves and that which makes us who we are. And so understanding that, for instance, our occupational part of our balance wheel, if I work 800 hours a week and I get no sleep and I don't get to exercise, or spend too much time on the other things, because the balance wheel is basically my whole piece of that pie is filled in with occupational, that means I'm really lopsided and not a very balanced person in my life. And incidentally, oftentimes people who have a way out of balance wheel are probably not as happy as they could be. Doesn't mean they're unhappy, but they could probably be happier, if that makes sense. And so this is a picture of the balance wheel, which I am gonna actually stop sharing and pull a different one up for you because I want to show you. And I want you to think about your own balance wheel. I'm going to actually let you go for 5 minutes to work on your own, but I'm going to bring up a handout first. Let me find it. There it is. All right. Once I have that open, I can go back and share it with you. I'm finding the balance wheel. Where are you? All right. So this whole handout, I actually downloaded it and uploaded it rather to the site. I took this from a website called morningcoffeewithd.com today. And it talks again about the different aspects of the balance wheel. Some people might only want to put 6 things in their balance wheel because these are things that are meaningful and important to you specifically. So not all of these things might be on your balance wheel. So I want to point that out because the balance wheel might make you feel like you have to have all of these things, but you really want to think about the things that are special, important in your life, and then decide, are you spending the amount of time that you want to, need to on those things. So in Dee's example, she has you fill out your wheel and basically connect all the dots, and I'll show you in a minute. So there's her blank wheel. Basically, if I say, I forget which end of it is. I think it's the middle is 0. So let's say physical health. I feel like I'm at a 0. I would put my little dot down here. Spirituality. Oh, maybe I'm I'm 50% satisfied where I am in that part of my life. Creativity. Oh yeah, I'm way up there. I'm going to give myself an 8. Whatever it is, if this is 0 and this is 10, I'm kind of figuring out where I am in each of these sections. And then she has you like connect the And so if I'm like zigzagging all over the place, then that wouldn't look very balanced. There's another exercise that you can do where you actually fill in that whole piece of the pie. So if this is my relationship piece, am I only going to fill a little piece of it, or am I going to color the whole thing in? And then I look to see what my wheel looks like, which I have an example of that too. And then here's your individual wellness, and again, I uploaded this so you have access to it. There's like a description for each of these aspects of self that talk about what role they play as far as your wellness, and what some examples of what we mean by financial, for instance, means taking steps to live within your financial means, living in, planning for future financial health. And you can do this by planning financially, creating a budget, and learning to be a good consumer. So for this particular wheel example, it actually gives you a little more detail around what kind of things go in there. And then here's another wheel. It's similar. And this looks more like an kind of an eco map already, or similar, but you can see that everything's interconnected. So rather than being a pie, this is sort of just a way of looking at it and understanding that everything overlaps. And it actually might, instead of the personal wellness word being in here, all of these might be closer and all be linked in the middle too. But it gives you some similar examples there. This came out of a website, plantingjustice.org, and they also talk about a balance wheel. And so I put that in there too, just to give you guys an idea. But what I want you to do is take like 5 minutes, no more than 5 minutes, and I want you to think about, actually, I'm going to put a picture back up so you can see a picture. Right here. Looking at spiritual, emotional, intellectual, physical. The one below is social. And I don't know how I'm going to make it a little smaller just so I can get it all in. There we go. Think about your own life and how much of the pie would you fill in, and then just do a mini self-assessment on where each of those, how you are with each of those areas. If there's an area here that is not important to you at all, you don't find any meaning to it, and it has no place in your life, then you can skip it. But for the other ones that are important, go ahead and take 5 minutes and do a balance wheel, your own balance wheel, and figure out where you are and what you might need to work on to help balance yourself out. Can you do that for 5 minutes?
Yeah.
All right. I'm going to give you 5 minutes. I'm going to actually just mute myself so you don't hear me. And I'll be back at 7:23.
Lori.
I'm sorry. I realized that I was muted this whole time I've been talking to you. I'm so sorry. No wonder you all see blank stares. I basically, I asked if you all were surprised at all by your balance wheels, if there were areas that you are planning to, pay some attention to at some point. I'm getting back because I'm trying to get back to, oh, shoot. All right.
Well, Lori, I can tell you about mine. This is
Okay.
Linda. Mine is being more social.
Okay. All right, good. And so you found that that's an area where you want to spend a little more time on, or a little more attention,
Yes.
paid a little more attention to. All right. Anybody else? Nope, that's okay. It was really for self-reflection, just to have you take a look at your wheels. Usually after people work on this a little bit, they come back and go, oh, I was really surprised. I didn't realize how lopsided my wheel was. And I know for me personally, if I were to do my wheel, I'd probably be a little lopsided with the occupational pieces. But I'm aware of it. And there are some other areas that I would like to spend more time, like physical exercise and that sort of thing. But it's just to be, well-rounded and well-balanced and all of that. So the important thing is that you just kind of thought about it for a few minutes tonight as part of our focus on self-awareness, self-care, that sort of thing. So when you look at the PowerPoint that I uploaded, you will see, and this is not in your materials, there is this guy called Wim Hof, and that is a three minute something video. It's in Swedish, and then there are like subtitles. Now, Swedish oftentimes can sound like English, and so you can make parts of it out, but some of it you really can't. So you have to read the subtitles. But this gentleman actually has proven to science that there are things that we can do with our mind, with calm, with breathing, that actually boosts our immune system and allows our body to do things that are just really amazing. So it's a pretty cool 3 minute video. And there's also, there's a website that if you just Google this guy, all kinds of stuff will come up. But I just wanted to point it out to you because it's kind of part of this whole idea of self-care and just the power of the mind and what we can do for ourselves as individuals. And then this is the meditation. I'm going to open this meditation and share it with you. And what I'd like to do though, before I start that, because when it's over, I'm gonna let you go to work on your final presentations. I do want to ask, I've got my 3 groups. Delphine and Yolanda is one, Jolene, Stacy, and Trent is another, and Theodora and Linda. Do you guys want to be put in a breakout room, or do you want to reach out to each other on your own and work together outside of a breakout room?
I think a breakout room would be beneficial for my group.
All right, and that's Trent, Stacy, and Jolene?
Yeah, I'd like to maybe hear from them, I guess, because I don't want to, maybe they're not thinking the same thing.
I think Stacy and Jolene, I think they do not have the ability to go into the breakout room. So what I will do is I will just leave you guys. Oh, I'll leave my thing wide open, but I'll turn my mic and video off, and you'll have the ability to talk and just use the Zoom space.
Okay.
Now, Theodora and Linda, Delphine and Yolanda, do you guys, your 2 groups, do you want to go into a breakout room, or are you just going to go meet on your own?
We've been meeting on our own.
Okay. That was one.
Linda and I are going to meet on our own.
Okay. So Jolene, Stacy, and Trent, you will stay on Zoom and you will have the Zoom room.
I actually just got a message from Jolene reminding me that she doesn't even have the ability to talk, but I have work there at 11:30 where I'll see Jolene. So I'll just go in early and talk to her.
Okay. Oh, okay. And then what does that mean for Stacy? Do you and Stacy want to talk
I'm-
for a few minutes or?
Well, I'm sure whatever me and Jolene talk about can just be translated to Stacy somehow. So I think we're all
Okay.
set. I think we're good.
All right. Okay. Sounds good. So let's do the meditation. And when that's over, I will, just say goodbye to everyone and you can work on your final presentation. But let me share. I'm stopping this share and I've got to do the new share, which I better still have that meditation up because I did have it up earlier. I don't quite know what happened to it. That's okay. I'm gonna,
Lori,
yes,
before you turn your mic off, me and Theodore have a question for you, okay?
sure, yes. What's your question? Or you want to ask it after?
We can ask it after.
Okay. All right.
Lori, I had a quick question. So I just was speaking with, chatting with Sherry, and if we could be put in a room just so I can, I'm gonna kick off my present, even though we're doing
Okay.
individual. Okay, thanks.
Yep. So, Dan, you want to be put in a room with who?
Sherry?
Dan and Sherry. All right, we'll do. All right. So can you all see 5-minute meditation?
Yes,
Yes?
I can see it.
Okay. Now, it's hard sometimes to do a meditation. This isn't the best one, but it's one that was short enough that I could use for this purpose. And so you can find these anywhere. They're just kind of cool. Sometimes if you just need a minute to breathe or whatever. So I'm going to play this for you and I'm going to not mute myself right now because you need my sound on so you can hear this. But you try to do your best to kind of close your eyes and put yourself in whatever mindset you need to really meditate.
Don't like veggies.
Oh,
What?
sorry about the ad.
Whatever you have at home, North Sides can turn
I'll skip
nutritious
it once it
veggies
lets
into
me.
mouth-watering meals. Veggies taste amazing with North.
Darren, thanks for gifting yourself these next few minutes. It's important to remember that you're a priority, and allowing yourself even just a few short minutes of intentional reflection can really have a positive impact on the rest of your day. So let's use these next few minutes to come back to center and set an intention for the rest of your day. Move into a comfortable position, whether you're seated at your desk at work or laying on the couch at home, and gently close your eyes and shift all of your attention onto your breathing, taking slower, deeper breaths than you've taken all day so far. Taking a deep breath in through your nose and slowly letting it out through your mouth. Continuing to breathe that way, feeling your lungs expand out as you inhale and contract back in as you exhale. Tune into your body, noticing how it feels. Noticing if there's anything that it's trying to tell you. Notice any place of tension or tightness in your body. Give those areas permission to relax, sending love into those areas. Thank your body for taking such good care of you, and let it know that it's okay to rest and relax for these next few minutes. You may notice that your mind starts to wander off. That's okay. That's natural. Just notice it and bring your attention back to your body, using your breath as your anchor. Try to picture one thing that's happened today that's made you smile, or made you thankful or appreciative. And just let that feeling fill you up for a moment. Breathe that feeling in from the top of your head to the tips of your toes. And allow yourself to smile if that feels natural. Now focus on something that you can do today, whether it's for yourself or for someone else, that will allow you to continue feeling this way. It could be something as small as deciding to go to bed early tonight so that you have time to finally read that book that's been on your bedside table, or the joy of getting dinner with a close friend. What's one little thing you can plan for your day to bring that intentional joy to it? Now just focus on that for a few minutes. Sit in that feeling of joy and peace. Now let's take a few more deep breaths together. A deep breath in, feeling your lungs expand out as you inhale. Everything contract back in as you exhale. Again, an even deeper breath than the one before it. Holding that breath for a beat and exhaling everything out. Last time, your deepest breath yet, sending that breath through your entire body. And exhale it out. And in your own time, fully bring your awareness back to where you are. And thank yourself for taking these few minutes to just be intentional and kind to yourself. And when you're ready, you can gently open your eyes and enjoy the rest of your day.
Okay. So how hard was that to kind of try to relax for 5 minutes? We don't do very well at this. This whole idea of just take 5 minutes and relax. It's tough. We're caregivers. And so when it comes to stopping long enough to care for ourselves, we don't do the best job. But this is reminding us to remember that you got to take care of the people who take care of the people. I'm sure you've heard that hokey saying, but I like that saying. All right, if you have questions for me, I'm here. And I think Dan and Sherry, I'm going to put you in a breakout room. Unless you have anything else for me, I'm going to do it now, which I actually have to go to my breakout room and recreate. All right, so it's just Dan and Sherry. Off you go, and I hope you have a good week.
You too, thank you.
You too.
Bye now. Now, did someone?
Okay. Lori?
Yeah.
Oh, this is Theodore and Linda.
Yes. Did you guys? Go ahead. You had questions.
Yeah.
I forgot who had the questions.
Yeah, we were just gonna ask you, is there any way you can possibly send the Balance Your Wellness activities through like our other emails, because we weren't really able to see everything through the Google Docs.
It's like all scrambled.
Oh, really? Okay. So when you try to open it up, you can't see it. Is your other email listed on the is it a Gmail, or you want a different email?
Actually, is there any way, because I noticed that you had yours up on the Microsoft app.
Yes,
Is there any way you can share it to that? Because I don't know
that
if
is what
that might work better.
yeah, that is what I uploaded. I uploaded that document.
Oh, okay. Because yeah, on here we were only able to access it through Google, and it wouldn't work.
All right, so I'm not sure how to make it stay a Word document if Google Classroom is changing it. Is that's what's happening? It sounds like Google Classroom is making it a Google Doc.
Right.
I'll see if I can override it and upload it as actually I can do it right now. All right, Quentin and Linda, were you two wanting to go? Oh no, you're doing your presentations alone. Did you two, if you two want to go and work on your final presentation, you may. I see Trent's still here as well. Don't feel like you have to hang out. If you want to go and work on your presentation, that's fine. We did carve out time.
I can leave right here.
And I'm happy to have you stay if you want. I'm staying open because I've got Dan and Sherry in a breakout room and I don't want them to lose their breakout room. Quentin, it's just you and me. All right, I am going to stop. We are officially done. I've got people in the breakout room, but otherwise there's no reason for us to stay recording. I'm going to turn this off.